Let's come to the curative setting. We have the esteemed panel of medical oncologists, but we don't have surgical oncologists. I wish we could have invited one. So, my question to you, you can take it start from Viraj and then on. Upfront surgery, adjuvant chemotherapy versus perioperative neoadjuvant chemoradiotherapy and surgery. What is your preference and why?
For gastric?
Yes. G-junction gastric.
G-junction, all patients undergo neoadjuvant strategy. Gastric cancer, still in our country, people often tend to do upfront surgery in early gastric cancers, T2, even T3N0s we've seen upfront being resected. But G-junction, I think so, in last 5-6 years, I don't remember any upfront surgery and coming to me as an adjuvant setting.
Any differing opinion by the panel?
Sir, most of our patients go perioperative neoadjuvant chemotherapy.
Right. So these are the trials, adjuvant trials, either KPOX, SOX, S1, and the RT trials failed, did not show any difference. But I must say that these are the trials which involved, by and large, the Korean, Japanese population, and there is a screening program. It is very difficult to pick up stage 2 early tumors, and I want your opinion, how many of our patients who are operated upfront are able to complete the adjuvant chemotherapy without any major hassle?
So again, in last 5 years, I can actually count with my 2 hands that number of patients undergoing upfront surgery, and especially where we have suggested it. It's very rare. We typically end up 9 out of 10 times doing perioperative therapy. And you are right, after gastrectomy or distal gastrectomy, especially total gastrectomy, it's very hard to finish your FOLFOX or KPOX. Typically we have to end up reducing the capecitabine dose, cutting down the oxaliplatin, and so on and so forth.
Any other differing opinion or any other comment on that? Maybe other panelists? Okay, so I think there are 2 meta-analyses, the first and second in the line,
Yeah.
and then there was a trial adding S1, DOS1, in the perioperative setting. All 3 have shown the benefit of perioperative therapy versus upfront surgery followed by adjuvant therapy. Correct. So all of you as panelists agree to consider perioperative therapy in our setting, and anyone has, please join us. So anyone has any preference towards upfront surgery and adjuvant chemotherapy after looking at this data?
So you're right, after Prodigy, and there was another trial which was randomized, 2 trials again from Asia, upfront surgery versus perioperative. Both showed at least 7% DFS advantage in favor of perioperative strategy. So I think so that closes the debate. However, if you ask a surgeon, a T2N0 on a scan, I'm sure they'll be tempted to do upfront distal gastrectomy.
Most of them, they will be found to have, they'll be
You'll get a surprise nodes.
Higher T and N stage. Okay, moving on. So maybe Dr. Trivedi, you not said anything till now.
Vikas, 1 minute.
Yes.
So the way we were discussing in the previous panel, S1 originated from Japan, doesn't have US data as yet. All the panelists are okay accepting S1 as the first line in perioperative or operative setting, na?
No.
No.
Categorically no.
Okay.
So yeah, that was important.
Yes.
So we do staging for all.
Yes.
Staging lab for all.
Okay. Anyone can, Dr. Trivedi or Dr. Sharma or Ramjas, NACT or NACT-RT? Any preference?
Yes, sir. So depend on the histology and the site of the disease. That histology, That is squamous cell carcinoma. And
Let's not go to squamous. They have discussed a lot. Let's go to adeno. Let's stick to adeno.
if it is adeno, then sir, NACT.
All of you agree with that? Any other comment?
Adeno's same, sir. NACT over NACT.
Yeah, I think we all agree that NACT is superior. In addition to the data, the fact is that it gives us more information about what other local therapy option may be. So NACT preferably.
Right.
So I'm a big proponent of FLOT, and now FLOT plus something. But if you are talking about CWAT1, a small CWAT1, 2 centimeter, 3 centimeter, we still follow cross protocol because it's easily well tolerated. And if we see ESOPEC, the main difference is in the distant metastasis rates. The locoregional rates are perfectly comparable to each other. So I know you're going to bring ESOPEC, but still in our practice, we have a radiation heavy practice. And for this small subgroup of G junction, we still tend to do cross.
So ESOPEC had about 50% 1 and 50% CWAT2, hardly 2-5% of CWAT3. And there is a huge difference. The number is here on the screen.
I know, I'm aware of.
So I think if you look at these trials, neoadjuvant setting, radiation has not shown any additional benefit. There are certain trials which have shown additional toxicity. And probably that's why I wanted surgeon, how easy is to operate after the neoadjuvant chemotherapy versus neoadjuvant chemoradiotherapy. Maybe you, Dr. Bhatt, you can add.
So it's not my area of practice, but I think that there is not much of a difference.
All right.
It's radiation doesn't add to much difficulty.
All right. But the trials have shown significant toxicity, in fact delaying the starting the adjuvant treatment as well. So by and large, if we say there is no additional benefit, do you really want to use the resources? Anybody in favor of adding NACT-RT, or even Viraj, are you?
So not adding. So in that case, we don't use FLOT, right? When we're using cross, there are several patients where we see 60 plus, not,
Yes.
so there is a place for cross still in our practice. Not everybody is 0-1 tolerating FLOT. And now if you're going to add IO, then IO plus FLOT. So I think so there is a space for cross still today in
Okay.
small subset.
Right. So if we consider immune checkpoint inhibitors in the perioperative setting, well, bringing this data, so you all are aware of this the addition of pembrolizumab to 5-cisplatin, and then the addition the adjuvant trial attraction 5, where nivolumab was given in the adjuvant setting. So these trials were negative. So do you think that the chemo base, I'm particularly talking about the Keynote 585, where 5-cisplatin was the chemo base. Do you think it was a weaker regimen and that led to this kind of disaster? GI ASCO, you were there, Viraj, with me.
No,
so maybe let others talk.
Yeah, so cis-5FU, I think it's not the best regime for this setting. Head and neck and that group of patients, upper with squamous maybe worked better. We know that cis-5FU fell out of favor even in adjuvant setting for adenocarcinoma long time back. So maybe that is the case, but I was a bit disappointed because I was very optimistic that we'll get positive data.
Sir, I think sir, chemotherapy backbone does matter, sir. That also we are giving the DCF in the esophagus squamous cell carcinoma, cisplatin we are giving. I think the immunotherapy different also. It's not all same immunotherapy work same. They are different in the efficacy also, in site-wise.
Right.
Yeah, so I think first of all, it was a doublet. And second, we hardly use 5FU cisplatin as our backbone. It's mainly Capox or Fulfox.
Yeah. So just now you mentioned you'll change 5-cisplatin. So I would probably say if you would have given Fulfox in that setting, would you use something like this?
In perioperative, we still wanted to use triplet although your own data showed triplet was not better than doublet, Anant presented it in advanced setting, but in still operable or resectable disease, we still end up using triplet more.
I think the downstaging associated with the triplet makes a lot of difference. It makes immuno to work, and there is a data which talks about increased immune response, immune sensitivity after using this kind of drugs, especially the taxane. The next trial which I'm going to ask you, and you discuss esophagus a lot, and of course this is the trial which used neoadjuvant CTRT, and then they post surgery they non-PAT CR they added nivolumab. So any patient, like Viraj said, there is a patient who will consider for FLOT versus neoadjuvant CTRT and then surgery, and then you will consider immuno. So any preference towards FLOT neoadjuvant chemotherapy versus NACTRT and surgery and then adjuvant immunotherapy?
No, sir. In the adjuvant, no. They are the new adjuvant. Float is better. We all know about the adenocarcinoma mainly. And if we use float after the good response with the surgery, then continue with the float only.
Right. So this was the data where the squamous component benefited a lot.
Squamous is different thing in
No,
adenocarcinoma.
yes, I'm agreeing with your point, and I'm just adding additional information. Adeno component benefited less, much less than the squamous component. The curves are not separating much. Any comment on this?
For squamous histology, we counsel it right from the beginning. If patient is affordable for the immunotherapy, then we'll prefer NSCTRT, then adjuvant nivolumab. If not affordable, then it's patient discussion.
It is
But
the
for
standard
adeno,
of care now, adjuvant nivolumab in the squamous histology there. If we give the NSCTRT, then the surgery, and if the residual, then the adjuvant nivolumab is the standard of care now.
But for adeno, you will prefer FLOT.
Yeah.
Okay.
Adeno.
So this was another Dante trial. Of course, the main data is awaited, and we have the PAT CR rate available, and which was presented last year. And Dante also used triplet and the addition of atezo. So here, if you remember my previous question about the doublet versus triplet, so the addition of triplet chemotherapy would improve the response rate, and we have a good response rate, especially with they have their subgroup analysis. Of course, it's an interim analysis. So would you consider any CPS or tumor area positivity for a particular patient in a perioperative setting? Would you ask for your patient or not ask for it?
In perioperative, there is matter only MSI.
You will not ask for
MMR.
CPS.
CPS in metastatic setting only, sir.
You will not ask for CPS.
Perioperative, no, sir.
Anybody looking at this Dante data? Of course, this is based on PAT CR interim analysis.
Because there are I feel there are the CTLA-4 inhibitors in the perioperative are more useful because of the immunogenicity. So they are the more role of the MSI, or they are the less role of CPS, because the PDL1 inhibitors are used with the CTLA-4. They are the greater result in that setting.
In the
Perioperative setting.
Okay, we'll probably stick to as of now this kind of data with the PDL1 inhibitors or PD1 inhibitors, and MSI will come to that data. But any other comment on this?
Yeah, so we don't need PDL1, but we often send it. But now on, I have started to counsel IO along with perioperative strategy.
Would you do CPS or TAP, and they say that if that is there, I will give
CPS.
Especially in the borderline affording patient?
Correct. So CPS more than 10 is where I tend to push them that please Lelo, it might benefit you more. I agree with you.
Anybody differs with this? Any comment on this?
So the data, my only question to myself and to my colleagues is, I have not used atezolizumab in this setting, and atezolizumab unfortunately has been like a less impressive in other settings. So I am a bit worried whether we should. There is a data for the pembrolizumab also with the CPS more than 10 or less than 10 with float, and they are equal with or without pembrolizumab. So I don't know about CPS 10.
Well, that's also a point taken. We'll not need to know more data about this, but probably if the patient is in a borderline setting, it's not that something you're counseling something wrong. But whether you will use Atizo or you will use Durva, that we'll see. So this was the Matterhorn recently presented this ASCO and published in NEJM. The design was very much straightforward, addition of Durva to FLOT and then 4 weekly regimen followed by the adjuvant and the maintenance 10 cycles. So they included tumor area positivity. How many of you have the ability to consider tumor area positivity at your setting or in your hospitals?
No, we just use CPS, and in my last presentation we did show that there is a 90% concordance, because the only difference is instead of counting cells, you just count the area.
Yeah.
So the TAP technically is much easier because you can like give a quick report, but still our pathologists do CPS.
All right. So in TAP less than 1, would you add durvalumab or no?
CPS less than 1, yes. Yeah, because we do CPS.
Yeah,
As I told you, but in borderline, like you said, which we often see these patients who are financially borderline, we tend to not push it.
Right. Okay. Moving ahead, there was improved PathCR rate. Obviously, this data was presented earlier, and then there's a difference of 12% and all that. And then if you combine the near complete pathological response, the terminology where we can include T1s and all that, there's a better kind of a response. Do you think that this kind of situation, this increased PathCR or increased response rate would have translated into survival, and we don't need adjuvant immunotherapy? Of course, these are of philosophy, but can you remove adjuvant immunotherapy if you have only neoadjuvant immunotherapy and good response rate? They're fitting into this criteria.
Sir, yes, in my opinion, if we have got PathCR in adjuvant, like in lung, the adjuvant role of
Here, will you do it?
So I am just correlating with other site that it may not be useful to give maintenance to give IO.
So I think so. This is a surprising subset where not only with IO, with FLOT, with HER2 and PER2 trial, remember Petrarca, these studies showed doubling or tripling of PathCR rates, but absolutely zero impact on any survival endpoints.
Yes.
So in G junction gastric cancer, one should be very skeptical in taking PCR as your final endpoint.
Yes.
We want a survival endpoint. If not OS, at least an event-free survival or relapse-free survival.
Absolutely. So that's the point where there are trials including the ESOPEC. If you look at there is an increased PathCR rate, but it is not translated into survival. So we have to be careful when we look at this kind of improved PathCR rate. Moving ahead, there was significant benefit in terms of 2-year event-free survival. Now, how many of you would agree that 2-year event-free survival is a very good, robust endpoint? You can comment on both 2-year and EFS.
Yeah. So just going back to the adjuvant setting, I just had a comment there that, before this, whatever trial we did, PathCR and conversion to R0 resection, that did not translate into OS. But also the interesting fact was everyone who recurred in spite of R1 had a distant recurrence. Majority of the patient had a distant recurrence rather than a local failure. So what that is telling us that there is a systemic aspect to this disease that has to be taken care of. So adjuvant and maintenance, I think, is pretty important. But 2-year data, very impressive, especially in this setting. If you look at, when we look at the forest plot, but this is actually that group of patients like, upper GI, where 2-year is possibly, if we cannot compare to other tumor sites, which 5-year is something that is very significant. But if patients have EFS at 2 years, it's quite impressive actually for this subset.
All right. Any other comment or criticism on this?
So this thing intrigues me. that why the two IOs didn't show benefit in event-free survival, and this one showed. Having said that, we have started offering this, but I still think, and Amol sir rightly says, it's the trial design which is at the fault and not the drug itself. I believe that the previous two trials which showed negative EFS advantage, somewhere there was a trial design aspect, and one of the reasons you said was the choice of backbone chemo. But again, that would only impact the PCR, not the event-free survival, right? That should have been better with the both other IOs, but it is not the case. So I don't know why this is positive and the other two are negative.
But just let me comment on that. Okay, let me just comment on this. The doublet is definitely inferior. That's the reason I made that journey of doublet versus triplet. Plus, we cannot assume that Dante will be negative. Why are you saying that it will be negative? Completely negative.
No, so there was one cross plus nivolumab trial also, RTOG trial, right? Cross plus nivo followed by surgery versus cross and surgery, completely negative. Now I would any day of the week bet on nivolumab, but that was completely on top of each other, and I don't have answer for that, and that intrigues me.
So can you just go back to the earlier slide with the two negative immuno studies? Yeah, there's this one. Yeah. So Viraj, just to say that the Keynote 585, the EFS was significant. It was 20 months. It's just that the OS was not different. It's almost double, 25 versus 44. So
it was not statistically significant.
No, I'm just saying that the difference there
the
was
number
20
was
months.
there. Yeah.
You know, in a study of 1,000
so it
patients.
was a trial design.
Yeah,
points,
so it was
right?
a trial design.
Correct.
And the fact that, you know, the OS likely will not, you know, did not come, but this was a very big difference.
So even the pembrolizumab did show EFS benefit, although not statistically significant. That is what he was referring to.
But there are two issues. The thing, after FLOT, when there is a recurrence, you hardly can offer anything. You can give something after the doublet you have given in the neoadjuvant or perioperative setting. Second, this trial used a 34% event thing for event-free survival calculation, which was probably, I think, it's a smart design, because to add on something to already a good survival given by FLOT, you really need to have a good design. So I don't say that it is not going to translate into it. Of course, the time will tell us. 2 years is a short. I was discussing with Anant, and I was only saying that 2 years is something not a good endpoint. We usually take 3 year is something which a useful endpoint. 18 months and 3 years. Any other comment on this? So when we look at the forest plot, we are seeing benefit almost in every group except a couple of other areas. Any comment on this? Those who have not spoken, Dr. Sudhir, or yes, you, Dr. Trivedi.
I am Dr. Sudhir.
Yeah, Dr. Trivedi.
So you know that lymph node positive, the high risk subgroup seem to be doing better than this thing, and that's why I was saying, you know, if you look at the forest plot, those high risk patients who have a very high risk of recurrence 18 months and 2 years, that is a bit something that we need to look out for. But obviously, you know, as the data matures, we'll have a bit of more clearer picture.
So there is a one slide which I did not add, and I agree with you that whoever had not only PATH-CR but also near PATH-CR, there the odds ratio was much better towards favoring durvalumab. But if I say there were about less Asians and they were mostly Japanese, and then the unity is crossed, I would be a kind of okay, I will say as a critic, I'll say it's not working. And the two trial, as per your thing, and at least one trial is negative. The adjuvant nivolumab trial is negative in Asian population. So I'm just playing as a kind of a critic. How would you defend that? or would you support that?
Yeah, mostly data from the gastric cancers, there are surgical data also from Japanese side. We follow that. So there is no problem in the.
Oh,
in
but
that
then probably then you will not add. So okay, see, Japanese was the only probably the major Asian country.
Yeah, for the gastric cancer
So
mostly.
you're saying that we can still use that data.
Yes.
Okay. Any other comment or criticism on this?
No, so I always like New York is not
because
Nagoya.
somebody just said S1 we don't want to use.
New York is not Nagoya. There was an excellent editorial in JCO, again when I was a research fellow. Somehow we know gastric and gastroesophageal adenocarcinoma in Japanese and Western, and we are somewhere in the middle. We don't have explanation that why it is different. Remember that gastric cancer surgery, I don't remember the Dutch trial, where the Japanese surgeons went to the Dutch centers to operate, still they could not give the same results. So there is something more than we understand, and it's again not only genomics as well.
Absolutely. So the Japanese screen the patients, so they find early. We have
no,
more
I mean even stage to stage. A T3N0 in Japan won't behave like a T3N0 in India.
Yes, and then there is like we have more distal tumor, we have more diffuse type. All these things should be considered. So I think again it will be the question where is there any molecular subtype which is benefiting more rather than a particular like a blanket treatment, how we looked at Topaz 1. But till then probably we are accepting the data. This point we already discussed about the overall survival, that probably we are hoping that survival will overall survival benefit will also be translated. Anybody is worried or not convinced that even though there is an EFS benefit, OS benefit may not translate?
I'm okay actually even if OS misses the endpoint. EFS in a curative setting, I just don't want relapse. This is not like a breast cancer where even if there is a relapse, we'll salvage it. This is gastric cancer. At any cost, I don't want relapse. So an event-free survival, as a philosophically, is a very much acceptable endpoint to me for GEJ adenocarcinoma.
Right. Any other opinion or comment?
No, sir. So like esophagus and gastric is a bad disease. So we will not wait for the OS. Something we have to add in that that we are doing. So EFS is okay, sir. Most of the trials that we are practicing is not only on OS only. On the basis of PFS, we are practicing also.
Right. So these are the toxicities, and if you look at the areas, I mean the graph, they're almost similar. Durva is not adding anything, and then we are probably comfortable adding Durva to Gemsys and then to this, and now Flot. So I think it will not be a trouble. How many of you already started giving? Ramaswamy, you're not raising your hand.
That's also started.
Okay. Coming to MSI high resectable gastric cancer, this is a nice meta-analysis. I mean, Anand gave me this slide. This chemo doesn't work, and then there is a possible scope for immunotherapy, and then we have this difficult to pronounce neonipigia or whatever, piga, whatever.
Neonipiga.
So whatever you call as Nivolumab study, NeoEP study. Would you consider upfront doublet immuno for MSI high gastric cancer, resectable?
100%.
Anybody differs on that? Anybody wants to still try Flot plus Durva? No? Yeah, if you look at the forest plot and subgroup analysis of all these trials, if you have MSI high tumor, their survival is different. In fact, those two negative trials had a small benefit which was because of MSI high tumors.
So again, that was my hypothesis, that those trials had only 3% of whole group as MSI high. I don't think so. Matterhorn has showed us, is it 7-8%? 7 to 8, little bit high. And you know, that explains why their curve is above.
Dante had more.
More than 8?
about 10 to 12%.
So then the EFS will be better. Because that's the only explanation.
So we all agree, as our esteemed panelists, and I want your comment, final comment, that we all agree that probably upfront surgery is not something for us. Perioperative is something we're going to consider, that too flawed, in a fit patient, and if possible, probably we'll add durvalumab to it.
Agree.
Anybody differs on that, or else we conclude the discussion?
So, just one final comment, so we all want our gold standard OS and those things, but what Viraj made a point, EFS in certain group of patients and maybe a large number of high risk group, we are, as medical oncologists, very happy because, there is no point in waiting for the best data while we have a good data. So good is good enough until we wait for the best, I would say.
Yeah, I think, and then there's nothing to add after that. And those who come post neoadjuvant, if they come node positive, especially N2, N3, we are in a difficult situation. And probably a maintenance therapies apart from maintenance chemo, something we can bring up. We'll have to see the subgroup analysis of this trial. Thank you very much. Thank you, panelists.
Thank you.